Greetings, everyone, and welcome to the ECG Case of the Week for the week of January 15th, 2018. This week, we've got a short case, a case that we probably haven't done in quite some time. This case was sent to us by Steve Hammond, who has sent a handful of other cases that we've reviewed. Steve is a paramedic in London, and he is happy to say an ECG nerd. I was going to say EKG, but since it's coming from the UK, we'll call it the ECG nerd. And he and his colleagues sent in a really, really great case. It gives us an opportunity to talk about something that we need to talk more about more frequently. This is a 63-year-old man that they were called to evaluate. This patient had a syncopal episode, and I guess some family members perhaps called the paramedics. They arrive, and the patient now is awake, but he's complaining of pretty concerning ACS type of chest pain. It's radiating bilaterally. He's got diaphoresis. So these are two really, really bad things. Radiation, especially bilaterally, and diaphoresis are two of the four really bad players in the history of present illness. The others being vomiting, chest pain with vomiting, and also chest pain that worsens with exertion. Those are the four real bad players, the components of the history of present illness that are associated with the highest likelihood ratios for that patient going to rule in for acute coronary syndrome. So again, chest pain that radiates, chest pain plus diaphoresis, chest pain plus vomiting, chest pain that worsens with exertion. Anyway, that's a little digression, but important stuff. And now on to the 12-lead ECG. Well, this patient has a paced rhythm. So what do you do with the paced rhythm? Again, we've talked about this before. Let's talk about this again. And can you rely on your 12-lead ECG? Of course not. Your ECG does nothing more than say it's a ventricular paced rhythm. Take a look at that. It's a ventricular paced rhythm, so I'm not going to look any further. That is what your ECG machine is going to have to say. But as we know, there is more that we can make from the 12-lead ECG. I'm sure many of us during our training were taught that if somebody has a paced rhythm, you cannot determine whether the patient has ischemia or not. Now, usually that's true, but there are some very, very important things that can be gleaned from the 12-lead, which may not have great sensitivity, but have very, very good specificity for ruling in for acute coronary occlusion, or essentially telling you that you're looking at a STEMI equivalent. So let's go through this. Let's talk about what a normal pacemaker does. Normally, pacemakers act just like a left bundle branch block pattern. Recall that with a left bundle branch block pattern, in every lead where the ECG points up, the ST segment is a little depressed. Pacemakers will do the same thing. And it doesn't matter what type of pacemaker you're using. Usually, almost always, the pacemakers are placed in the tip of the right ventricle, which produces a left bundle type of pattern, gives you a leftward axis, and it gives you that appropriate discordance. So again, QRS points up, so you expect a little bit of ST segment depression. QRS points down, say V1, V2, V3, the QRS points down, and so it's normal to have a little bit of ST elevation. If the J point is isoelectric, that would be okay also. In this particular case, in V1, V2, V3, the J point's elevated in the opposite direction. That's totally normal. In this particular ECG, you see just a lot of isoelectric flattening out laterally, but the key point here is that when you see a pacemaker, you should normally expect to see discordance between the ST segment and the QRS complex. Again, QRS goes down, the ST segment or J point should be a little bit elevated. QRS goes up, we expect therefore to see the ST segment or J point a little bit depressed. That's normal. That's referred to as appropriate discordance. If you lose that discordant relationship, you ought to worry. Again, this is the same thing we've talked about with the left bundle branch block pattern, and as you recall, back in 1996, a very, very smart cardiologist by the name of Elena Sgarbossa published 3 steps or 3 criteria which would, with very high specificity, fairly high specificity in the presence of a left bundle branch block pattern, predict that the patient is having essentially a STEMI or acute coronary occlusion. And I'm just going to call these Sgarbossa A, B, and C. What she said was that if the QRS goes up, we normally expect there to be a little bit of ST segment depression. But in this case, if there's ST elevation in the same direction as the QRS complex, call it a STEMI. We call that Sgarbossa A. Again, not always very sensitive, but very, very specific, probably better than 90% specific. So you can hang your hat on the fact that that patient's having a STEMI. Sgarbossa B, what she said is that in leads V1, V2, or V3, those are the only 3 leads that this was shown to work reliably. What she said is that normally in V1, V2, V3, the QRS normally points down. If the ST segment is also depressed, then that is an acute coronary occlusion. I call that Sgarbossa B. And then Sgarbossa C, what she said was that normally when the QRS goes down, we expect to see ST segment elevation, but if you see more than 5 millimeters of ST segment elevation, so there's the ST segment and there is the J point, this is more than 5 millimeters. It's too much elevated. If you see excessive discordant elevation, in other words, the QRS points down and the ST segment normally is a little bit elevated, but on the other hand, if the QRS points down and the ST segment is more than 5 millimeters elevated, that's too much. And she said that that predicts a STEMI as well. Well, as you recall, with left bundle branch block pattern, Sgarbossa C turned out to not work that well. But she also found that these same 3 criteria do actually work for pacemakers as well. And for pacemakers, it appears that Sgarbossa C does work as well. So all 3 of these rules that we originally learned for left bundle work for pacemakers also. So if you ever see Sgarbossa A or B or C with pacemakers, you should really worry that that patient's having an acute coronary occlusion, and the literature has really backed that up. There's articles that go back quite a few years, back in 1996, when the first articles were coming out, and articles have come out since that time. The most recent study that I've seen is this one from 2010, and in this article, once again, it validated the fact that Sgarbossa A, Sgarbossa B, and Sgarbossa C criteria all are very reliable when you're looking at patients that have pacers. How sensitive is it? Well, not that great. Probably less than a quarter of patients with pacers that are having STEMIs will demonstrate Sgarbossa A, B, or C. But if you see it, it's enormously predictive that they are having a STEMI. In other words, not great sensitivity, but very, very good specificity. And that's why you need to know about it. Because if you see it, then you are almost certainly looking at a STEMI equivalent, or in other words, an acute coronary occlusion. Let's look at some examples. Here's a case that was sent by Dr. Jim Campana, a former resident who's working up in New York. This is a 38-year-old woman who came in with chest pain, and this patient has a pacemaker. Actually, the pacemaker is kind of subtle. There's very, very little spikes. Pacer spikes have gotten smaller and smaller, but anyway, just trust me. This patient has a pacemaker, and what you notice is in leads 1 and AVL, the patient has concordant ST elevation. In other words, the QRS goes up and the ST segment is elevated in the same direction. And this person went to the cath lab and had a big LAD occlusion. Here's a patient sent to us by Dr. Trent Stevenson from Texas with Sgarbossa B. In lead V2, the QRS complex goes down, and we expect that the ST segment ought to be elevated a little bit. And instead, what we see is that the QRS complex goes down and the ST segment is depressed in the same direction. So this patient has that Sgarbossa B in lead V2. And by the way, I didn't say this earlier, but in order to meet the Sgarbossa criteria, you only need 1 lead. You don't need 2 contiguous leads. That's how good this stuff is. Just 1 lead buys you a trip to the cath lab. And if you use thrombolytics, it probably ought to buy you some thrombolytics as well. Here's another patient. This one is sent from Sweden by Dr. Nicolina Anderson. In Sweden, actually, the ECG machines are a little bit smarter than back here in the US, and the ECG machines actually put little hash marks at various stages of the QRS complex and the T-wave. So at the beginning of the QRS complex, you get a little red mark. At the end of the QRS complex, and then at the end of the T-wave, there's little red marks, so it makes it very nice and easy for you. This patient also has Sgarbossa B in lead V1 or V2 or V3, where normally you have the QRS pointing down. We normally expect to see a little bit of ST segment elevation, But when that QRS points down, if you have ST segment depression in the same direction as the QRS, that person is having a STEMI. And you can see that in this example, lead V2 and V3 both meet Sgarbossa B criteria. And here's an example sent from Ohio by Dr. Patrick Bress. Here's an example of Sgarbossa C. Recall what Sgarbossa C is. Normally, when the QRS complex points down, we expect to see a little bit of ST segment elevation, just a little bit, but when that QRS complex points down, if the ST segment is more than 5 millimeters elevated in the other direction, that's too much. That's referred to as excessive discordance. That's that Sgarbossa C finding, and there's a whole bunch of leads where there's too much elevation. You notice the QRS complex goes down, and let's see, there's the isoelectric point right there, and that is about where the J point is. That's more than 5 millimeters of excessively discordant ST segment elevation. Lead V3 is probably even better. There's the isoelectric point, and the J wave's right around there. That's about 7 millimeters of ST elevation. In the opposite direction, there's a couple of other leads also. This patient has Sgarbossa C, and this patient also went to the cath lab and had a big LAD occlusion. Now let's go back to the case that we started with. This is the case where the ECG machine is not helping at all. So let's go through this step by step. Do you see any leads that demonstrate Sgarbossa A? Recall, Sgarbossa A means the QRS complex goes up and the ST segment or J wave is also up in the same direction. Let's see, which leads have a QRS complex pointing up? Well, lead AVR is just about the only one we see here, and in AVR the QRS complex goes up and there's actually ST segment depression. That's normal. So there is no Sgarbossa A. Is there any Sgarbossa B? Remember, what is Sgarbossa B? Sgarbossa B means you look at leads V1, V2, and V3. Normally, in V1, V2, V3, the QRS complex goes down. If you see ST segment depression in the same direction as the QRS, then that means that you're looking at a STEMI. In leads V1, V2, V3, you really don't see any ST segment depression. The leads are a little bit difficult to interpret, but let's see. There is the end of the QRS, and if we just trace this right up, let's see if I can make a straight line here. That is the end of the QRS complex in lead V2, and it does not look depressed, and we'll keep going north, kind of wavering a little bit, but right about there. Once again, it doesn't look like there's ST segment depression, so this patient does not have Sgarbossa B either. Now, what about Sgarbossa C? Are there any leads where the QRS complex points down and there is excessive ST segment elevation? Well, looking around this 12-lead ECG, you really don't see more than 5 millimeters of ST segment elevation. So this patient actually has no evidence of Sgarbossa A or B or C. So why am I showing this to you? Well, let's go back to the case. What actually happened here? Well, the patient was looking really sick. And for that reason, Stephen and his colleagues took the patient to a cath facility. They bypassed the closest facility and drove just probably a few extra minutes to the cath facility that's nearby. And when they got there, the cath team looked at the 12-lead ECG and said, well, wait a second, this is a pacer. You can't read ischemia in this patient. And even if you did, maybe the cath team was looking for Sgarbossa A or B or C, and there's none of that. And they said, you know what? This patient doesn't qualify for cath. You should probably have gone to the closer facility. This patient doesn't need cath. It certainly doesn't need to be bypassing closer hospitals to go to the cath center. Well, the patient was still looking pretty bad, so they got another 12-lead ECG, and now take a look at this. This patient now has both Sgarbossa B and Sgarbossa C. We'll look more closely at that. Again, Sgarbossa B, recall, in V1, V2, or V3, where the QRS complex goes down, if there's ST segment depression in the same direction, and sure enough there is, there's ST segment depression in the same direction, so that one lead would buy this patient a trip to the cath lab and predicts that this patient's having a STEMI. This patient also has Sgarbossa C. Let's take a look at that first complex. Remember what Sgarbossa C is. The QRS complex goes down, and there's more than 5 millimeters of ST segment elevation. So you're looking at more than 5 millimeters of ST segment elevation. This patient has both Sgarbossa B and Sgarbossa C. So with this repeat 12-lead ECG, at that point, then cardiology goes ahead and takes the patient to the cath lab. On arrival, the patient ended up having a cardiac arrest on the table. Can you imagine if this patient was still in the emergency department with the cardiac arrest? There's a much less chance of survival, but this patient fortunately is in the cath lab. They're ready to go. They're ready to open up that artery. What better therapy could there be for a patient who's having cardiac arrest from an acute coronary occlusion? Open up the occlusion, right? Well, that's what they did. They got return of spontaneous circulation. They did a PCI, and I think the patient ended up having a big LAD occlusion that they opened up, and the patient thankfully had a good outcome, but very nearly a disaster. But the disaster was averted for two reasons. Number one, because they knew what to look for in terms of Sgarbossa criteria, and number two, because they had the smarts to go ahead and get a repeat 12-lead ECG. Remember what we said many times before. When your first ECG is non-diagnostic, but your patient's looking bad, get a second ECG. Get a third one, because sometimes the second or the third one is your diagnostic 12-lead ECG. Okay, quick take-home points. First of all, remember, you've got to know the Sgarbossa criteria. Sgarbossa criteria are useful not only for left bundle, but they're also useful for pacers. They tend to work pretty well for pacers. And when in doubt, get a repeat 12-lead ECG. Now let's go back up to this take-home point up here. A lot of you are probably thinking, well, wait a second, the Sgarbossa criteria for left bundle and let alone for pacers, those are not in the current national guidelines, not here in the U.S. and probably not in the European guidelines either. American Heart Association, American College of Cardiology, they may kind of mention it a little bit, but it's not clearly stated as a class 1 recommendation to go to the cath lab. And the reason is that in order to make it to class 1, or the highest evidence base, you've got to have large studies. And the simple fact is there are no large studies. There's certainly no large randomized studies that have been done on pacemaker patients that are having acute coronary occlusions. So I don't think we are ever going to see the Sgarbossa criteria for pacers put into the national guidelines, because there just aren't enough patients to put together a 50,000 patient multi-center randomized type of trial the way we have for many of the other things that are in the guidelines. The studies are too small. Does that mean that we should ignore it? Of course not. Just because it's not listed in the guidelines, just because there's not very large studies, doesn't mean that you shouldn't have to know it. You've got to know this stuff because it makes a huge difference in terms of patient care. The articles that we have are relatively small, and because they're not in the guidelines, many of your cardiology colleagues may not know about this. Many of your own colleagues in the emergency department or internal medicine or family medicine may not know about this either. So grab these articles and share this literature with your colleagues. Spread the word. Everybody has to know about it. Otherwise, a lot of patients are going to slip through the cracks and have bad outcomes, just the way our patient that we presented here could very easily have had a terrible outcome if he had gone to a non-cath type of facility. All right, folks. Well, my thanks to Stephen Hammond for sending us a great case to discuss, and also thanks to all of his colleagues who took great care of this patient. I hope this case was helpful, and I look forward to talking to all of you next week. Bye for now.